Good morning, friends. Welcome back to my YouTube channel, Medical Classes by Dr. Srinidhi Kumar Acharya. Don't forget to subscribe my channel and also to give the comments. Thank you very much. Friends, in the last class we are discussing about shayya mutra, and we have covered the first part of shayya mutra, where it involves different types of shayya mutras, different causes of nocturnal enuresis, and some other basic information regarding the same. And today we will proceed with the clinical aspects of shayya mutra. That is, clinical understanding what are all the common questions during the interrogation with the child or parents. Now the first question is, at what age the child consistently dry at night? This question has to be asked with the parents. If the answer is he is never dry till now, then it is a case of primary enuresis. As we know that in case of primary enuresis, the child is never dry. If the answer is again restarted after having, if the answer is again, they say that it is restarted after having a control over a few months, then it is secondary enuresis. If the parents say that, doctor, he has got the control for 6 months or few months, then again he started with this problem, then this particular condition is secondary enuresis. Now if the answer is child is wetting at night since birth along with the daytime enuresis also, and also there is urgency along with other symptoms, he is also having some other symptoms, behavioral symptoms, etc., then it is considered as complicated enuresis. So this is the first step that we have to understand. We have to differentiate whether this particular shayya mutra is of primary enuresis, secondary enuresis, or complicated enuresis. It is done by a simple one question. If the child is never dry since birth, child is never dry at night since birth, it is primary enuresis. If the child started the shayya mutra after having a break of 6 months, then it is called as secondary enuresis. And if the child is also having daytime incontinence, nighttime incontinence, along with some other symptoms, along with urgency, etc., increase of frequency, urgency, etc., then it is complicated enuresis. Now ask the second question, whether the child has got problem only in the night or in the daytime, or both day and night both, along with the daytime incontinence. So what you have to ask is whether the child is having got problem only in the night hours or only in the daytime, or whether it is in both day and night. If the answer is yes, this may be suggestive of cystitis, overreactive bladder, and ectopic bladder. That means in ectopic bladder or overreactive bladder and as well as cystitis like conditions, there is no differentiation of day and night. There is existing pathology inside, and therefore it causes problem at any time. So this is a second important question that you have to ask to exclude the other different causes of shayya mutra. Now in this particular case, it is not at all a case of shayya mutra. It is these particular problems which are causing the problem, and it is mimicking like shayya mutra. Okay, it is not the actual real shayya mutra or nocturnal enuresis. These overactive bladder or cystitis or ectopic ureter, etc., are making the baby to void the urine involuntarily both in day and night hours. Okay, so this is not nocturnal enuresis. Okay, so this is how we have to differentiate. This is the second question. Third question, what about the constipation in the patient? Don't forget to ask this question. Always ask whether child has got constipation. If my parent says yes, if the answer is yes and constipation is there, then it may suggest various causes of constipation and encopresis. Now we know that encopresis means it is abnormal passage of stool in an inappropriate time and inappropriate place. Okay, encopresis is such a psychobehavioral condition where the child passes the stool at an inappropriate place and inappropriate time. This is actually of two types. One is associated with the constipation, another one is not associated with the constipation. Encopresis is also common in those child who are having constipation. We will discuss about encopresis in some different sessions. So here yes, parents say that yes, my child has got constipation. This is a big problem for him since beginning. Now the other suggested questions are now, how does the child have the bowel movements? Suppose if you are not able to ask about the constipation or you are not getting the correct answer, even the parents are not knowing exactly about that, then you can ask what about the bowel movement, whether he is regularly passing or whether he is passing to solid stools or tight stools, okay, so blackish stool, etc. So such leading questions can be asked. Now, are the bowel movements are associated with the pain or bleeding? This question may be also asked. Or does the child have the stool or large enough caliber to clog the toilet? Or does the child will have an unintentional fecal voiding? These are some of the other questions that you can ask related to constipation and encopresis. Okay, now if the answer is yes, suppose child has got the constipation or encopresis, if the answer is yes, then constipation itself is the cause of nocturnal enuresis. As I told earlier, the constipation, there is a loading of the fecal material in the colon, and that put pressure over the bladder area, and as a result bladder is get irritated and there will be passing of the urine irrespective of the time. Most commonly when the child is relaxed in the sleep, in the deep sleep, this is quite common. Now one more question that you have to ask is about sleep apnea, whether the child has got sleep apnea, obstructive sleep apnea we will say. Does the child will have the sleep apnea? Does the child will have snoring, or whether it is gasping of the air, whether the child has got mouth breathing, whether the child has got cyanosis, whether the child has got daytime intolerance or daytime somnolence, that means sleepy and he is moving in his own world, okay, less reactive to the environment, daytime somnolence, whether the child is irritable, whether the child has got ADHD like symptoms, whether a child has got pulmonary hypertension, poor academic performances. These are all the questions that you have to ask. If the answer is yes to many of the above questions, then mostly it suggests obstructive sleep apnea. Obstructive sleep apnea means, so there will be snoring, and the snoring followed by sudden awakening of the sleep, and the snoring, as I explained in the last class, because of the snoring and all, the tongue falls back, and as a result the brain receives less oxygenation, and as a result there is awakening state. Suddenly baby is continuously loudly snoring, and suddenly baby is getting up with the apnea. There is stoppage of the respiration, so suddenly child get up. Okay, then again it go to the sleep. So this is called obstructive sleep apnea. This is common in obesity, this is common in adenoid phases, this is common in some other cause of mouth breathing like nasal congestion, deviated nasal septums or tonsillitis, etc., or enlarged tonsils, etc. Okay, so these are all the outcome of such obstructive sleep apnea. If there is obstructive sleep apnea is there, then usually the child will have daytime somnolence, child will have, because he is not having the sound sleep, disturbed sleep, therefore he will have irritability, he will have ADHD like symptoms, okay, poor academic performance, he is not able to concentrate in the class, he will feel sleepy. So these things will be there. So if answer is yes for many of the questions, then the child is having obstructive sleep apnea. And this obstructive sleep apnea is also one of the most common cause of nocturnal enuresis. Now another question that you have to ask is about the functional bladder disorders. There are disorders called as functional bladder disorder. There is no structural problem, but functional bladder disorders are there. For example, you can ask some of the questions like does your child has to run to the bathroom? That means urgency is there. Does your child holds the urine until the last minute, so he is not passing, so he has got a bad habit of withholding the urine, okay, or vegadharma? Or does your child wet more than once at a night? That means in one single night, child is voiding or wetting the bed for 2 to 3 times, not only one time, 2 to 3 times. So if answer is yes in for most of the above questions, then actually that child has got functional bladder disorders, and this functional bladder disorder is the cause of nocturnal enuresis. So usually child pass urine in a daytime for more than 7 times. Okay, In the night, usually child passes the urine. Suppose an active child, normal child, usually he passes, maybe may not pass at all if he is going at that means before going to the bed, if he is passing the urine, and if he is getting early in the morning, mostly he will not pass, or if he pass also once in a time, once at a night. But sometime child may pass the urine in the bed 2 to 3 times. So that is not a normal phenomenon. That is because of functional bladder disorder. There is overactive bladder is there, okay, over functioning bladder is there, some irritation is there for the bladder muscles and all. So such causes may be the cause of nocturnal enuresis. Now, how to differentiate the functional bladder disorders and nocturnal polyuria? There is a condition called as nocturnal polyuria, which we have seen in the last class. Okay. Now, how to differentiate between these functional bladder disorders and nocturnal polyuria? Ask some of the questions. How many nights in a week does your child wet the beds? In a given week, how many times does every day child passes the urine at bed? Okay, every day there is nocturnal enuresis is there, or once in a week is there. So such questions you have to ask. If the answer is most of the night he passes the urine, then it is a functional bladder disorder. Okay, and if the answer is once in a week or sometime once in 10 days like that, or once in 3 days, etc., then mostly it is nocturnal polyuria, because functional bladder disorder means every day it will be there. Every day it will be there. Okay, so daily he will pass. But if it is nocturnal polyuria, because of, as I told in the last class, because of some problem in secretion of ADH secretion, okay, there is less formation of ADH in the deep sleep. So that is leading to less water reabsorption and passing of the urine. So that is called as nocturnal polyuria. So in these conditions, daily the child is not passing the urine. Okay, so nocturnal polyuria. So we know that nocturnal polyuria is one of the most common cause for enuresis, nocturnal enuresis. One more thing is, in case of functional bladder disorders, if the child passes urine, the amount is less. He may pass many times, but amount is less. At night, he may pass 2 to 3 times per night. Okay, but still the amount is very less. Okay, it may be in terms of ml, a few mLs, 5 ml, 10 ml like that. But if it is a nocturnal polyuria, the amount of the urine which he passes is very much. Large amount of the urine has passed, because water is not retained and it is going out. Okay, so parents usually say, sir, he passes urine so that whole bed sheet is wet. Large amount of whole bed is spoiled and whole bed sheet is wet. So this is actually nocturnal polyuria. Okay, so if a large volume of the urine voids in the bed, it is nocturnal polyuria. So if he passes small amount of the urine, it is functional bladder disorder. So this is how we have to differentiate. So why I am telling this, in Ayurveda when we say there are some conditions related to mutra kritra, okay, mutra kritra. So where child passes, urgency is there and frequency is increased and associated with some other symptoms. So now we have to differentiate it between the mutra kritra and as well as shayya mutra also. Okay, so one more condition is prameha, as I told. Diabetes mellitus is one of the important cause for the same. So even in case of prameha also we have to differentiate. Prameha, mutra kritra, shayya mutra, this has to be differentiated. Now next question is, have you tried any treatment? You just ask this question to the parents. Have you tried any treatment? And look at the patient's reaction or parent's reaction. Be alert for responses suggesting that. That means, so as soon as you ask this question, have you tried any treatment? Then immediately observe the facial expression of the parents. So they are usually looks frustrated. So what they say is, sir, we have tried everything. We have tried everything. So child has been punished also. Child has been shamed also. Still he is not improving. These are the reaction from the parents. Okay. Now you have to be careful. Okay. So in that time you can understand the mentality of the parents. That means parents are not supportive to the child. Now half of the problem is exaggerated or increased by the parents' reaction only. If the parents are able to keep themselves cool and calm during the situation, and if they try to understand the situation of the child, then probably this problem would not have been reached this extent. Now half of the problem is increased because of over anxiety of the parents and frustration of the parents. Okay, so as soon as you ask this question, you've come to know that a child has been punished for many times, child has been shamed in front of others. Okay, then you ask whether there is any stressors like birth of the new sibling in the family. You ask this question, or they may tell that there is a death of the relatives in the family. Okay, so they may also tell that there is trouble in the school. So you may also come to know that there is some child abuse, family conflicts, divorce, sibling disparity, etc. So as soon as you ask this question, everything will be understood. Okay, so asking this question is very important. Have you tried some treatment? So then they reveal all the history, what they have done so far. Okay, so this is another important question that you have to ask. Ask whether the child is bothered by the problem. Now this is very important. Okay, so if you want to correct the problem from the root itself, first of all, the child should be mentally ready for that. Child should think that yes, there is some problem because of me, and I should come out of it. And then only the problem can be solved. Once the child is not in a position to agree that I have got some problem, then how you can correct it? So it is our duty to make the child understand this problem. Okay, child may be too immature in that age to educate and to give the awareness, but still at a child level we have to make him understand, see boy, this is the problem, definitely you can come out of it, and only thing is you have to follow my some of the commands, you just do like this, like this, like this. So you can take the child into confidence and you can try it. So question is, ask whether the child is bothered by this problem or not. You must check it. If the answer is no, if the mother says, no sir, he is not at all worried and we have to suffer out of it, and he is not at all worried and he don't know himself, he in the sleep he is passing the urine, how come he know? So then what is required is the behavioral modification is unlikely to be successful if the child is not interested to participate. Okay, so first make the child aware. Okay, yes, you have got some problem and we know that it is not done intentionally, you are also innocent in this case, but we want to correct it to prevent some of the complication and to prevent the future problems and to prevent the insult that you are facing. So we will help you. So like this you have to educate the child, and then if you do behavioral modification, then the child will be responsive and it also gives a good result. So child education is very important. Active involvement of the child is also very important, and counseling of the child is also important, and also child may be confused. Sometimes child is knowing that something is going wrong, but child is confused. He don't know whether this is a problem that is intentionally making or non-intentionally making, because everything is happening in the sleep. He don't know anything. Okay, so only after looking at the after effect, he come to know that something has went wrong. Okay, so therefore he is also confused. So clear this confusion and give a correct vision, and then try to go for some behavioral modification. So key questions. So in the clinical assessment, the key questions are: nocturnal enuresis, never dry, it is primary. It dry for more than 6 months, it is secondary. Wet pants during the daytime, and there is urgency, and there is also dribbling is there, then it is complicated. There is a history of chronic constipation is there in the child. Then the infrequent stools, hold it on and ask about the fiber diet, low fiber diet, etc. Or it may be because of overactive bladder. And if the diabetes mellitus is there, there will be infrequency, loss of weight, and vomiting will be there along with the nocturnal enuresis. Okay, if you are suspecting about the diabetes mellitus as the cause of this nocturnal enuresis, then there is increased frequency. It's not increased frequency, it is increased frequency. There is loss of weight and some other vomiting and some other symptoms will be also there. If the cause is child abuse, then it is common with the secondary bedwetting or regressive type. It is common in child abuse. Sometimes parents will aggressively react on this reaction. So they will scold him, they will beat him, they will insult him in front of everybody. Okay, and they will spread this news and they will give some punishments, and they will ask him to wash the bed sheets and all those things, many things. So a kind of child abuse. So this is quite commonly leads to common in secondary bedwetting. Okay, similarly, punishment, scolding, beating, etc. Look at facial appearance of the parents while complaining. Okay, many times when parents complains, you look at the facial expression of the parents, as I told earlier. If they are very irritable and their facial expression suggests that they are frustrated, and then it suggests that they are fed up of this problem and they have tried everything. Okay, so they have tried beating, scolding, and all these things. So therefore, reading the parents' face is also very important, because many times child may not review that fact. The child may not review the fact that my parents are scolding me, because he is afraid of them. So look at the facial expressions of the appearance of the parents. Then only you come to know. So then we have to think about urinary tract infection. Okay, if it is a cause is urinary tract infection, UTI, etc., then there will be pain also sometime. Okay, so there will be pain. Sometimes there will be hematuria, dysuria, or dysuria means pain, or abdominal pain, suprapubic pain. So such other other symptoms will be also associated. So ask the question with the child: have you got any idea that what is causing this problem? So understanding the child mentality is very important. You, in a separate room, isolated way, you ask with the child: my dear kids, my dear friend, do you know what is actually happening? Do you know why these your parents are scolding you? Do you know why everybody is shaming you? Do you know everybody is confused why? You separately call him in an isolated room and ask this question and look at the child's answer and reaction. Okay, so then only you can come to a conclusion that from where I have to start the treatment. Okay, now talking about the history. In the history, the careful elicitation is very important. The careful voiding history, that whether the child needs to be weighed or pushed to initiate the voiding, that has to be taken. Look at the urinary stream, whether the stream is very strong stream, continuous stream, or whether it is straight. Okay, these are the points. I will explain this. And you have to also take the sleep history. If the child goes to the bed, falls asleep, and awakes in the morning, that means he has got a sound sleep. There is no disturbance in between. Or sometimes there is a disturbance in between, like obstructive sleep apnea. Okay, we know that in a sound sleep or deep sleep, this usually the child will pass the urine. Okay, then timing and number of wetting episodes, that also you have to take in the history. And history of restless sleep, snoring, and type and frequency of nocturnal arousal such as nightmares, sleep terrors, and also sleepwalking. This history should be also taken. Okay, sometimes child may have nightmares, sleep terrors, and sleepwalking. Such type of history you will get. All these histories are very important when you are taking the when you are treating the nocturnal aneurysms. So what I am explaining is a very well coordinated and basic way of treating the nocturnal aneurysms. It should not be treated blindly. We have to go by cause. Especially when you are dealing in Ayurveda, the Ayurvedic treatment is not according to the disease. It should be go by cause. Then only you can get the success. So now, education of the patient. History part, we should always take the history of urinary stream, sleep history, and history of nightmares, and the sleep hygiene, then voiding history. So these are some of the important history, family history. These are some of the history part that we have to take. Yes. Now when we are evaluating the patient, it should be seen as whether it's a primary, secondary, nocturnal, or diurnal. This is another now. So first decide. This particular decision is very important. Okay. For decision, this much of explanation is required. Knowledge is required. Okay. Whether it's primary, whether it is secondary, nocturnal, and diurnal. If the primary, treatment differs. If secondary, treatment, mostly psychological treatment, behavioral treatment, you have to give reinforcement treatment. Reinforcement treatment has to be given. Okay. Then see whether it is nocturnal or diurnal. If it is diurnal, some other overactive bladder or small bladder capacity, that may be the cause, or UTI may be the cause. If it is only in the nocturnal, it may be nocturnal polyuria, or it may be diabetes mellitus sometime, or it may be some other constipation like symptoms. Does the encopresis is associated? Now this is about the urine passing. Encopresis means passing of the stool. So baby is also having encopresis problem along with this nocturnal aneurysms. Then again your approach will going to change. Okay, so you have to first treat the encopresis, because encopresis there is a constipation, and that constipation is putting the pressure over the bladder, and that is causing the problem. So once you treat the constipation, then the things will be corrected. So go for some constipation treatment, go for some mild virechana drugs, okay, anulomana drugs, then that can be well treated. Instead of giving so many drugs, just go for an anulomana drug or just go for a virochanopaga drug like avipatika churna or something like that. Once the constipation is clear, this problem is also clear. So this is the importance of going step by step. Otherwise, we will miss the track. Simply giving by some of the drugs like some major drugs and all, it will not going to help. Anyway, again you see associated with the urinary tract infection like dysuria or polyuria. If it is dysuria, again you have to treat accordingly. UTI you have to go for, okay, either you have to treat the urinary tract infection first, go for Shweta Parpati, go for Trina Panchamula Dikvata or some other preparations. Okay, so you have to treat UTI first. Now look at the developmental history. Okay, developmental history also, because if the child is having mental retardation, if the child is having developmental milestone delay in developmental milestone, then this particular enuresis is also, nocturnal enuresis may be also part of the delayed development. Okay, so if the child is normal and active and just like other normal kids, then it's a different issue. But if the child is also having a developmental delay and along with that child is also having nocturnal enuresis, then the development delay should be given more importance, because this particular problem of nocturnal enuresis is part of the developmental delay. You have to also look into the neurological deficit if it is present or any other CNS disorders. Family history, because family history plays a very important role. Most of the time when the child is passing the urine, nocturnal enuresis is there, you will get a positive family history either in the parents or any other family members. Then even the family environment is also important. Okay, so husband and wives are quarreling, there is some familial complex or divorce and daily quarrels. Okay, nobody is there to care the child, nobody is there to talk with the child, nobody is telling the story at night. Okay, so then all these things directly affect the child, and it may lead to or precipitate to nocturnal enuresis. Now, how to start consultation with your patient? When the patient comes, how to start the consultation? Assess the fluid intake and the toileting. Assess the fluid intake and as well as toileting. Now, are you restricting the fluid and how much fluid he is taking? And is there any toilet nearby? See, these are the very important questions that you have to. Is there any toilet nearby? Nappies, or who cleans it afterwards? Washing is more annoying than the warding to the mother. Actually, parents, especially for the mother, washing the wet bed sheet stained by the urine is more painful than the actual problem of the child. Okay, so mother is irritated by that fact. So now, so you have to ask all these questions. Okay, so first, how much fluid he is taking? Okay, and what about his toilet training? Now, then you ask, are you restricting the fluid in the evening hours? And per day, 24 hours, especially after evening, how much of fluid he is taking? And if there is a toilet near, this is also one of the cause. Baby is sleeping, child is sleeping in one room, and toilet is there after 3 rooms. Okay, no, child has to go there. That too in the midnight when he's in deep sleep. So by that time he can pause. Or sometime by thinking that toilet is too far away from me, so he may be lazy to get up. So these are some of the basic things you have to understand. Okay, so you ask this question whether it's any toilet nearby. Now, by asking all these questions, then you have formulated a hypothesis. What are the main DDs? Okay, what may be the main DDs? Most likely the nocturnal enuresis. Nocturnal enuresis may be primary, may be secondary, or may be complicated, or constipation. That may be the cause because of loaded colon, putting pressure and causing urination at night. So these are the 2 important causes. Okay, either it is a primary, secondary, or complicated type of enuresis, or it may be nocturnal polyuria, or it may be constipation. Then you less likely causes of nocturnal enuresis is child abuse. These are not common causes. Okay, these are less likely. Most common causes we have seen either it is primary, secondary, or it may be because of constipation or complicated type. Less likely causes of nocturnal enuresis are like child abuse, maybe UTI, maybe diabetes mellitus, maybe diabetes insipidus, maybe some of the structural and congenital problems, and maybe genetic. Sometimes no causes are found. That also you find in the clinical practice. Okay, we have seen such a detailed explanation, but you didn't find any causes. Still baby is body. That is a genetic tendency. Okay, if the father is also doing the same, mother is also doing the same, then this problem will be more. Just what I told in the beginning itself. There is some autosomal dominant fashion of inheritance has been seen. Okay, now sometimes very rare, but some serious problems may also cause this problem. That is diabetic ketoacidosis. That may be also one of the cause. To understand the reaction of the parents after voiding, whether they are angry, punishing, insulting, scolding, etc. If so, it is you have to correct it. Okay, so that is also important because we told that it's the parents who are increasing this problem. So parents has to be educated well. Okay, so as a physician, as a pediatrician, you also see the reaction of the parents, how they are reacting to this situation. Now, start with the open question. When the patient comes to you, introduce yourself and have empathy with the mother and understand already that mother is emotionally upset. Ask her, please can you tell me more about your child's bedwetting? See, this is another. When mother comes to you with the child having shayya mutra, you will ask all the details and mother will be more frustrated because she is already fed up of telling these stories to many doctors. Okay, maybe. Okay, and she is the one who has to suffer more and she has to wash the bed sheet and all those things. So she is emotionally upset. Number three, she has got more love and concern about child and she has got the feeling that something is bad is going on with my child. So she is emotionally upset. Now, as a physician, as a pediatrician, you have to console her. Okay, ask her, please can you tell me more about your child's bedwetting? More about. That means it suggests that we know about your problem. Now we want to get some more information. So this will not create much pain and emotional disturbance to the mother. Okay. So how many times in a week and how many times in a night does there is a large amount of the, so casually you ask the question, how many times in a week he will do it, or how many times in a night he will do it, or whether he is passing large amount of the urine or whether he is passing small amount of the urine. Okay, so such questions you need to ask. Does the child wake up after bedwetting? Sometimes this also happens. After passing the urine in the bed, child wake up. Okay, so sometimes baby is passing, child is passing the urine, you don't know. In the morning only he come to know that. Okay, so this gives a clear idea that whether he wake up to does or she feel that he is bedwetting or not. So these are some of the important points, clinical interrogation with the patient. And with this, we conclude today. The next part is about the physical examination and other treatment aspects in Ayurveda and as well as in the contemporary field. And that we continue in the next class. Thank you very much. Don't forget to subscribe my channel and also give the comments. Thank you very much.